So for those of you who have missed our previous sessions, you can access the recording slides and other resources on the iEcho platform. So feel free to have a look if you're interested in any of the previous sessions as well. And with that, I'd just like to say thank you to everyone, and I'll hand over the session to Norman for any housekeeping and announcements before we start. So over to you, Norman.
Thank you, Preeti. Just a very quick housekeeping rules. I'm sure a lot of you are already familiar. If you've already joined us from the first session, if you haven't, please do rename your screen name to your name, your area of expertise and country, so that we'll be able to capture that data from our side. If you have questions or you have reflections, please feel free to use the chat box, and we encourage you to turn on your video as well for an interactive learning environment. This again, as mentioned earlier on, this session is recorded, and we will also upload all learning materials on the iEcho platform. Something new that we are adding this time around is a translated caption option. If English is not your first language or your primary language, we have also included this option here where you can listen to the content that we are talking about in the session and have a real-time translation into your language of preference. If you look at this slide here, Joseph, can you shift to the slide where we have this button? Yeah, this one, the previous one. Yep, this one. You see that you need to toggle that translation on, and also you need to choose your speaking language and the caption that you'd like. If you would like to speak in French and you'd like the caption to appear in French, just feel free to toggle that option to the language of your preference. We are also cognizant that this instruction that we're saying is also in English, and this picture is also in English. But if you look around in this room, and you know somebody who can benefit from this instruction, please feel free to help them if you know that they need assistance. All right. Next would be CPD points. So for Malaysian clinicians, we'll share a form, a Google form where you can provide your information, so that we can submit that to MMA for them to process your CPD points. Clinicians from Japan, you can submit the certificates of attendance to JSAR after you've completed the feedback form. Clinicians from Australia as well, we will submit your name to ASHM, and they will process your CPD points. The clinicians who are S100 prescribers. Okay, with that said, I think we are ready to dive into the content for today.
Thank you, Norman. If anything is unclear, feel free to drop us a text in the chat box and we'll give you a hand. So moving to our didactic session, it is my pleasure to welcome one of our hub members, Dr. Kejal Hasmukharay, a friend, colleague, and geriatrician at the University of Malaya Medical Centre in Malaysia. She specializes in internal medicine and geriatric care with a special interest in immuno-senescence, infections in older adults, and identifying pre-frailty in seniors. Dr. Kejal is a committed advocate for preventive medicine, passionate about empowering older adults to embrace active, healthy aging. Today, she'll be speaking to us about decoding frailty in clinical practice. So I'll hand the session over to you, Dr. Kejal.
Thank you very much, Preeti, for the kind introduction. And hello, everyone. Before I go on to the didactic lecture, maybe we could put up the poll prior to the presentation. Okay, so this is the first question. Who from the below two older adults with HIV, of course, this is an AI generated image, is more frail? If you look at the two patients, image 1, image 2. Your options are essentially either 1, 2, both of them are frail, you think you need more information, or none of them are frail. Do try to answer the question and then we can discuss about it, maybe after the presentation so that we can have more time for Q&A as well.
They will have to answer both questions.
And the second question is, in your best understanding of the concept of frailty, which of the following best defines frailty? Disability due to minor stresses, loss of physiological reserves, slowed motor function, or muscle wasting? Probably give 30 seconds for answering both the questions. And Norman, you'll be able to share the results, right?
Yes, I will.
All the responses, Norman, coming in.
Okay. Yep, we currently have 34 responses and it's stabilizing at 34. Would you like me to end the poll?
Yeah,
Okay. I'm ending the poll
let's see.
and I'm sharing the results.
Okay, so 21% actually said image 1, the lady is more frail compared to the second one. But 59% said they need more information. Good. And the second question, best understanding, it's about 50% said loss of physiological reserves, and then the remaining said slowed motor function, muscle wasting, and disability. So what I'll do is I'll leave you to think about what the best answer is. And at the end of the session, we'll definitely rediscuss this just so that, though I hope by the end of the session, you probably already know the answer. Okay? All right, so let me share my screen now so that you see my slides?
Yes.
Okay, so I'm going to start. Okay, so hello everyone. The polling question was intentional there, just so that we can, jog your mind and put on your thinking caps about decoding frailty in clinical practice. It's a term that we use very, very commonly in clinical practice, and I think it became more popular during COVID because a lot of rationing of ICU ventilation admission and all that was actually partly based on clinical frailty scale. So this is just the outline of my talk: understanding frailty, screening for frailty, interventions for frailty prevention and management, and some of my take-home messages. So what really is frailty? It's a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserves and function across multiple physiological systems, that the ability to cope with everyday or acute stresses is compromised. So it's highlighted increased vulnerability, aging-associated decline in reserves, and the ability to cope with everyday stresses is compromised. So If you had gone through, or later, if you're free, if you can go through in our resources that we have uploaded, there's a very nice frailty fulcrum video for you to better understand the concept of frailty. So what it actually means is someone who is robust, fit like you and me, if you have any stresses, and this can be anything, a fall, infection, heart attack, admission for pneumonia, heart failure, you probably will be a little down, and then as you're slowly recovering, you'll bounce back to actually your pre-admission state. Someone who is pre-frail, during the stressor, they would dip down. They would take some time to recover. Some would bounce back to their pre-frailty state, pre-admission state. Some would take a longer time before they can bounce back. But what you actually see in people who are frail, any stresses, and this can be really even a mild stressor of a non-major injurious fall, for example, at the point of time when they have the stressor, as they're recovering, they will almost never go back to what their baseline was. They end up getting more dependent, and then disabilities kick in. So essentially, it's just saying that their physiological reserves get depleted as time passes, and they can't cope with even minor acute stresses. So what really causes frailty? I know this diagram is really complex looking, but what I want to do is we will go through it together so that we can understand. Yeah. So when you read the paper, this paper is actually saying the effect of physical activity in improving frailty. But I love this concept for us to understand. So what we see in our patients is basically slowness. They have got reduction in physical activities. We see them getting weaker. We see them getting slower. But what really happens is actually a lot of dysregulation in various levels in our physiology, in the endocrine system, in the hematopoiesis system, in how we respond, as well as at the cellular and molecular dysfunction. So let's start here. So when we age, we get cellular senescence, so aging cells. We have got poorer ability to repair. We have got changes in our telomere lengths. We also have got mitochondrial dysfunction. And we know mitochondrial is where we actually get our ATPase to fuel our energy, our cells. So particularly cells that require high turnover, especially our nervous system, our muscles, they tend to have poorer response. And because of this system or these changes that happens at the cellular and molecular levels, this then results to troubles in physiological regulation in terms of the gonadal hormones, in terms of how our body responds, stress hormones, in particularly basically the pituitary, hypothalamus pituitary axis hormones, the nervous system response, glucose dysregulation, because what happens here at the molecular level eventually causes insulin troubles with insulin sensitivity, and this then causes one person who is aging to have persistent inflammation. So all these changes that we're talking about causes inflammation. Now, this inflammation and a lot of these other changes that I'm talking about, the stress response, the altered gonadal hormone response, the hematopoietic response, leads to changes in our muscle strength, in our muscle mass, which then leads them to have weakness, poorer motor response, reduce in strength. The hematopoiesis system, essentially, when we talk about anemia, poorer response, this then leads them to feel very exhausted, reduced effort tolerance, and ultimately leading to poorer physical activity and even weight loss. So essentially, it's a cycle that goes on, but it starts right from the molecular level, even at the level of our DNA repairs and also mitochondrial. So now the problem with this frailty is actually it's a complex cycle. So don't get worried, we'll just go through this one. There are four essentially main things that's driving, right? Sarcopenia, which is basically muscle wasting. Often people say is the other part of the coin when we talk about frailty. When we talk about sarcopenia, it's not interchangeably, but basically sarcopenia is just wasting of the muscles. So let's talk again for people who presents to us with lower strength. So what really happens, someone who has got poorer strength, they have got poorer walking speed. Why? Because of their sarcopenia, muscle wasting, they have got reduced oxygen consumption, they feel very tired easily. Also medical illnesses, whatever, in people with HIV, they are multi-morbids, they have got persistent inflammation because of HIV, because of the drugs, because of the comorbidities, then persistently leading them to have exhaustion. This then leads them to have reduced walking speed, reduced physical activity, and when they walk less and do less, they have got lesser energy expenditure. Then when we try to balance their intake and their energy balance, they then end up going into a chronic undernutrition state. Of course, there are many other factors, anorexia of aging, which is then actually led by a lot of neuroendocrine dysregulation. This chronic malnutrition leads to weight loss, and then this drives the muscle wasting again. And so basically this vicious cycle leads them to have more disabilities, more dependency, and eventually getting more and more frail. So the only way we can break the cycle of frailty is if we can intervene at any point here so that they don't get into this vicious cycle. Now, if you're going to think about frailty in general population, we always like to talk about the different types of frailty. We have got physical frailty, essentially reduced physiological functions that will increase our physical vulnerability, as how I showed in the cycle earlier. But what we often don't realize is also there is cognitive frailty, where someone who has got physical frailty, as well as evidence of cognitive impairment, but without the diagnosis of Alzheimer's or any other form of dementia. So essentially, mild memory issues, and physically they are already frail. So that's cognitive frailty. Social frailty, it's a continuum of being at risk of losing or having lost resources that are important to fulfill basic social needs during the lifespan. Think about our patients with HIV. They often have got isolation, stigma, and they are at a higher risk of getting social frailty, and also oral frailty, which has become a bit more common, and been quite a hype about this in the last decade or so, where there's decline in oral function, which impacts a person's ability to chew, swallow, and speak. Now, how common is it in our patients who are living with HIV? This study is rather old. It was done in the MAC study in 1996, but what this study essentially shows that as someone grows older, and even though with just a short duration of HIV, the prevalence of frailty-related phenotype actually increases. So even at the age of 55, someone with just about 8 to 12 years of HIV, the prevalence of frailty is about 13.4. The study also tried to look at what's the odds of developing frailty based on the duration of HIV. So someone who was just newly diagnosed in the last 4 years, their odds was about 3.3. But by them having had HIV for at least 8 to 12 years, their odds of developing frailty is almost 14.6 times higher compared to the general population. And what's interesting is that the frailty prevalence of a 55-year-old man living with HIV, someone who acquired HIV less than 4 years, is comparable to a seronegative man who is 65 years old. So what I'm trying to show is basically there is not just accelerated aging, but there's probably also accentuated aging. So one is when the aging process gets accelerated because of the comorbidities. The other thing is where HIV almost becomes like a hit button, and that accentuates the multimorbidity and frailty or any other geriatric syndromes that was supposed to happen probably at a later age. This is another study that actually shows the prevalence of frailty when you compare someone who is HIV positive, even at a younger age group, 45 to 50 years old, you can already see the prevalence of HIV is way higher in the HIV group versus the general population. So I think it's time for us to see how we learn how to transition through the biological age. I think sometimes we are so bogged down thinking about the chronological age that my patient is only 50 years old. It's unlikely he could have cognitive issues or frailty. But I think we need to understand what's the impact of HIV and the drugs on the biological aging, like the inflammation, the telomere length, the cellular senescence, the mitochondrial dysfunction. If you think about it, all these that it's mentioned here, it's also the pathophysiology that's driving frailty in the general population. So essentially what it means is having HIV is an added risk factor for developing frailty. On top of that, the impact of HIV and the medication on the determinants of aging, smoking, drug abuse, substance abuse, multimorbidity. This issues on top of aging will then lead them to have less physiological response, cumulative loss of function, more vulnerable to any stresses, eventually leading them to frailty and increasing care needs. So what we see here is someone who is quite well, not disabled, any acute stresses, they might become transiently disabled until they pass through the threshold beyond which they will actually deteriorate. A lot of times they actually bounce back and go back to no disability, but if they are already frail to start with and they have passed the threshold of what the body can cope or what their physiological reserves is, they end up becoming more and more frail, and then they end up having more disabilities. What are the consequences of frailty? Essentially falls, disability, hospitalization, institutionalization, mortality, caregiving burden, and also increasing healthcare expenditures. Now comes the important question, how do we screen for frailty? Because now that you have understood the concept of frailty, how it can actually affect our patients who are growing older, and these are just some of the frailty screenings that have been used in the general population. Actually, there are many more, but I've just listed 5 here, which are actually being used in the HIV cohort. Of course, the most common ones that have been used is actually the frailty phenotype and the frailty index, which has also been validated in this group of HIV patients. I'm not going to go through all in detail. It's also there in our resources, but I'm just going to go through a little to say that, frailty phenotype essentially just requires you to have a dynamometer, basically a JAMA to measure the grip strength, and a stopwatch to see their walking speed. All the rest of it is basically self-administered questionnaire, where any score that you get above 3 actually says that your person has got frailty. Has this been used? Of course, it's been widely used in research. It's also used in a large Dutch HIV cohort, where they compared 500 patients with HIV with 500 general population. The European AIDS Clinical Society guidelines uses or recommends frailty phenotype to diagnose. Okay, frailty index, on the other hand, is like different questions, almost 30 questions, where they are trying to do like a continuous score. Has this been tested in the patients with HIV? Yes, but what they found in 2 different studies, Italian and Canadian studies, that a mean cutoff of 0.3 may suggest frailty, which is a little different from our patients in the general population, where the suggested cutoff point is 0.23. Then we have got the Edmonton Frailty Scale, Frail Scale, and CFS. All have been used, almost quite comparable with the frailty phenotype. And I just wanted to highlight to you that the Frail Scale, which is just 5 questions, you can ask the patients, or it's almost self-administered. You don't need any other equipment. It can be done within 2 or 3 minutes. Is what the European guidelines recommends for screening purposes. So if you're thinking of how do you now initiate this discussion, or at least start thinking about looking for frailty in your patients, then maybe starting off with something simple would be good, and then moving on to something that requires a little bit more training or a little bit more equipments. So you don't always need to have equipments. You can always start talking about it during your usual clinical consultation. So I'm just going to show you this clinical frailty scale. In the geriatric population, we love using CFS because it's very easy. You can almost determine your patient's clinical frailty scale during your clinical consult. And this is exactly the same score that was used at its peak during the COVID, when they're determining who gets into ICU and who doesn't. So don't need to memorize the algorithm, because there are apps for it, which I'll share with you. But when you have a patient in front of you, how do you really start talking or initiating the conversation? So I think the right way is just asking, how have you been feeling in the last 1 month? Go by what they respond. Oh, I feel very well. I feel excellent. Or, I'm not feeling so good. And when they tell you a response, probe a little bit more to see how you can understand a little bit more on what's going on. So say they are feeling very good and they have been excellent, or they're feeling overall, good. Then move on to ask about their exercise. Do they exercise? And if they do they exercise regularly? Because that actually can help you determine almost whether or not they are mildly frail or they are otherwise robust. So once you have identified their ability to exercise, whether or not regularly, not regularly, strenuous exercises or not, then a quick question: so do you need any help, outside the home, like managing your finances, shopping, transportations, and all of that? And based on that, that can also roughly give you some idea on how much assistance they need. And if they already need some assistance in activities outside the home, then you need to explore on how much of help they need for their personal care in terms of dressing, bathing, eating. So this is just roughly that you can explore before you move on to say, oh, here, this is your blood test, your CD4 is good, your viral load is suppressed. But this is just general conversation, which helps you build a rapport as well as understand your patient a little bit more. This is some apps. Actually, you don't really need to memorize the algorithm. If you have got iOS, if you're using Apple or Android phones, you can actually download these apps, just 8 questions, and then eventually they tell you what's the result of your patient. Or if you're comfortable with just asking them these 5 questions, whether you're feeling tired, do you have any troubles walking, and have you had any weight loss, you can also roughly gauge your patient's frailty state. Now that you have understood that your patient are frail or they are already pre-frail, what do you do? What is it that you can offer for your patients? Quite a lot. So
Kejal,
interventions for
just to let you know, 5 minutes.
noted.
Thank you.
Interventions for frailty is basically multimodal: physical activity, nutrition, managing their medication, managing their mood and cognitive issues, and addressing the other issues. So I'm going to talk about exercise because I'm very passionate about this. I think we need to normalize prescribing exercise. We seem to be very comfortable prescribing statins, our ARTs, but we just almost end up at, do you exercise? Okay, good. Or you don't? I think you should. But what happens next? How do you tell your patients what do they do or what should they do? And before we talk about what do they do, it's always important to just roughly understand the person in front of you. Are they robust? Are they pre-frail? Are they at risk of falls? If they have, then you don't want to, advise them on something which cause them to fall. Simple questions of asking them about their balance, doing a simple chair rise, asking them to get up in front of you in your clinics, testing their walking speed. You don't really have to measure, but really when they walk into their clinic, you roughly can gauge. But ideally, a formal assessment would be good. Risk of fall, these 3 key questions. Once you have identified that the person in front of you, say, is robust or frail, with or without falls risk, you can roughly advise them on what kind of exercises they can do. I want to share with you, if you're thinking that exercises may not be that useful after all, this is a study. It was actually a randomized controlled trial done in patients with HIV. You can actually see in the intervention they actually showed significant improvement in terms of their fat mass, resting heart rate, and even improvement in their muscle mass and the CD4 T cells. Now, how do you prescribe? This is an amazing guide for you. I love this. This is actually Frail. It's an app. Download this, and then based on what you have assessed your patient, of course, this app will tell you step by step, the balance, the chair rise, the scoring. So what's the patient's ability in front of you? So this is what I normally just show my patients. So this is what you need to do. You start walking for about 5 to 10 seconds, then you rest, try a bit more, 10 to 20 seconds at week 1, and then you try to upscale it a bit more. Squeeze ball, lift a bottle. So all these simple exercises are basically for someone who is mildly frail and at risk of fall. If you think your patient is otherwise robust, these exercise wheels are actually very good because there's some aerobic training, there's balance training, and also resistance training. So at the side of the legends here, you will see how they are slowly asking them to move up the ladder in terms of the frequency and also the intensity of the training. So simple exercises like these, when you ask them to do, will be super, super important. Secondly, there are a lot of barriers to adopt exercise in people living with HIV. It could be personal factors, interpersonal factors, and even environment factors. What really helps is you and the patient sitting down and planning for their life together in terms of exercises. So this is a nice slide from the Exercises Medicine website, where you can see you and the patient decide that I'll start with maybe walking, then I'll gradually increase to walking twice a week. What's the intensity that I'll try? How many minutes? What are some of the strength training exercises I can do? You sign, the patient sign. You make them feel that they also have the authority of their life in their life to decide how they want to improve their lives. And I think this kind of behavior change strategy is important so that the patients and us are on the same page. Okay, then let's talk about nutrition. Nutrition is super important because we want to also balance out muscle growth against muscle loss. When we talk about nutrition, we need to make sure we address poor dentition, ensuring they have got no swallowing issues. If they've got any deficiency, we need to address that. Look at the medications. If there's any problems that's causing anorexia, address it. Target weight management in those with obesity. We're very good in thinking about obesity in cardiovascular risk, but not really thinking about how obesity also leads to frailty. Quick nutritional screening. This is an MNA, mini nutritional assessment, that you can use. Otherwise, quickly asking them, have you had weight loss? Have you recently had reduction in your food intake? Can already roughly give you an answer on what their nutritional status could be. Management of frailty in terms of nutrition is mainly protein because you need it for your muscle mass, on top of the usual fruits and vegetable servings that's needed as part of healthy eating. Now, polypharmacy is very common in our patients with HIV because we know because of the accelerated aging and the comorbidities, they tend to have a lot of other medications. This polypharmacy leads them to have more accumulation of toxic effects, eventually leading them to have falls, delirium, hospitalization, and mortality. What can you do? Every review, see back the medication. Is it indicated? Is the dose correct? Any other interaction? If there's any alternative that you can offer, look for it. For better sleep, do you really need sleeping pills? Or you can do cognitive behavior therapy, better sleep hygiene, dyslipidemia, diet modification, hypertension. We tend to always jump on high BP at office, but sometimes it could just be white coat, chronic opioid use, physiotherapy. I think we don't use our rehab colleagues' expertise enough. Pain management can be done a lot through rehab physicians with a lot of different intervention without requiring painkillers. BS criteria is a criteria that we geriatricians love, essentially to identify drugs that are potentially inappropriate. I put a QR code here for you for a quick pocket guide. And also, if your patients are at risk of fall, remember the three key questions I mentioned earlier. Identify what are the risk factors for falling and intervene wherever you can potentially modify, whether it's vision, hearing, postural drops, instability, whether they are using the right instruments when they're walking. Mood issues really need to be managed because we mentioned about cognitive frailty. Mood and cognition is very interconnected because mood is essentially pseudo-dementia. You need to address the mood first before you can address your cognition. Frailty, mood, and cognition almost always go hand in hand. So once you identify one risk factor, you need to try to treat it, intervene it so that you can prevent them from getting into the vicious cycle. Because if you don't, then they end up getting cognitive and also say socially frail. Social determinants of health, this is basically the definition from CDC, but what's important is basically these are the determinants of condition that's allowing us to to grow, work, and live in our environment. And if you think about patients with HIV, they have got so many different factors that actually can put them at risk of actually being socially isolated. It could be individual factors, social economical factors, or even health factors. And if we don't address these factors in them, they are potentially at risk of even defaulting medication, dropping out, having non-adherence to treatment, having poor lifespan, and eventually leading to death. So if we have addressed all their medical issues, but we're ignoring their social determinants, and we will realize that these patients are definitely not going to do well. And I think we don't seem to do very well when it comes to social prescribing. We always talk about medications, but we often don't talk about how we should prescribe them activities to get involved. I've just put in some pictures here. This is U3A. It's a university of third age, university for older persons aged more than 50 years old, to join in some activities that they can do to learn new skills, interact and mingle around with friends. We have got seniors allowed. The one with the red ribbon here essentially centers around our region that is actually done to allow people with HIV to meet, mingle, and socialize. And so as much as we prescribe ART, prescribe exercise, social prescribing is also important to give them an avenue to actually socialize and improve their cognitive and social health. So I think it's time on how we change the lens of how we manage our older adults living with HIV. We were here doing very well. I think it's time here where we start assessing for frailty and other geriatric syndromes. And then it's time to now work together with other colleagues in other departments. In other departments so that we can start intervening early before they continue deteriorating. But what's the current recommendation? I'll just quickly go through it. Like I've mentioned earlier, the European AIDS Clinical Society recommends using the Frail scale, 5 questions to screen patients. And the US guidelines essentially suggest us to use the frailty phenotypes for people aged more than 50 years old. The Australian guidelines essentially says consider screening for people who are at risk by measuring gait speed, chair rise, and also grip strength. This is basically the algorithm, but what's important is it's important to just start screening even during your regular clinical consult or even through a quick screening tool of Frail scale. And then once it's positive, you can intervene by definitive diagnostic tools. So this is my last slide now. My take-home message is HIV is associated with earlier onset and higher prevalence of frailty. Screening is much needed. Decide on how you and your center wants to start. It doesn't need to be something so hi-fi, but even quick screening during your conversations would be very helpful. Multi-domain interventions beyond HIV care in terms of CD4 and viral load are proven methods to manage frailty. We really need to urgently shift our paradigm on how we see total HIV care. And we can all do our part in maximizing health span. I'm not going to say lifespan, but health span for our patients and vitality, not to just add years to their life, but actually life to their years. With that, thank you. I'm happy to take questions.
Thank you so much, Kejal. That was really a whirlwind, but very in-depth talk on frailty. So I'll open it up for questions because we went a little bit over time. Maybe we'll have about 5 minutes of discussion if that's okay. So can I invite anyone for questions? For the Hub members, feel free to just unmute yourself if you've got any questions. For participants, if you're shy, you can either put up your hand and unmute yourself, or you can put your question in the chat box.
Hello.
Hi. Hi,
Hi, Grace
Grace.
from Hong Kong. Hi, Kejal, thanks very much for your talk. A very practical question. So it might be difficult in clinic settings to do a frailty phenotype. So the frail scale or some of the simpler screening tools are actually more convenient. So if a patient does screen positive using, for example, the frail scale, do you think we actually can recommend the nutrition, exercise, prescription that you have mentioned, or we really do have to perform the gait speed or the other assessments?
So thank you. Very good question. So no, actually you don't have to. If you really want to, what your idea is to screen them, pick them up early so you can intervene. Now you need to make sure that when you reassess them back, you are actually using the same tool so that you can see that your interventions have worked. So even like a quick, chair rise or a walking speed, and then when you reassess them back, say 6 months later, at least there's a way for you to objectively measure that something has improved. Weight has improved, mood has improved, walking speed has improved. So at least in our clinical practice, the moment we pick them up that they are frail through CFS, we love using clinical frailty scale because just through regular conversations, you can already gauge how frail the person is. And then we talk about nutrition, social prescription, look at their oral. When we see them back after 6 months, it's going to be the same questions again, but then we would have documented that now no longer having troubles with walking up the stairs or, no longer reading, no longer having recurrent falls in that measure. So you don't really need the definitive tool as how it's recommended, because sometimes with busy clinic it's really difficult. It's nice in a research context, but really in busy clinics it's almost impossible. But we need to make sure that the way we are measuring this, it's almost the same in every follow-up so that you can see objective improvements along the way.
Thanks, Kejal. I think Jenny has a question and there's one question in the chat. So we'll take Jenny's question first.
Thanks, Kejal. That was fantastic. My question is about commencing screening at the age of 50. I think that there's probably some patients who have significant comorbidities that may become frail before the age of 50. And then, of course, there are people who are 60, 65, 70 who are not frail. But we pick this arbitrary 50 to start screening. And I just wonder whether we should be saying to healthcare providers, look at the person in front of you. And if they're below 50 and they've got multiple morbidity or multimorbidity, start screening earlier or start assessing earlier rather than screening. Because I often think that I think we as clinicians know when someone's frail. We don't have to do all of these tests, that we know this person is frail and what are we going to do about it? And I just wondered what you thought about that.
I think it's a very good point. Why the figure 50? I also think because a lot of studies have showed that they have got accelerated aging, about 10 years compared to the general population. That's why. But when you mentioned that we physicians know that our patients are frail, that can only come by talking to them beyond their HIV viral load and their lipids and their sugar levels. So routinely asking them about their ADLs, how much of help they need beyond outside the house, inside the house, that will help. So I totally agree with you. It doesn't need to be a cutoff of 50, and you shouldn't only start screening people who are already looking frail, because you want to try to pick people who are already even at the pre-frail state. So they don't look frail. They have got fairly good physiological reserves, but if they have an acute stressor, they are going to tip down. You want to pick them up early so that you can build them up, build their reserves. So whether the figure 50 or 45, I think the recommendations have said 50, but like you rightly said, we know our patients best. So if you're conversing with them and they say, in the last 1 year, I've slowed down a little, just simple things like that, I've slowed down a little, it's already such an important window of opportunity for us to ask a little bit more. Why do you feel so? Is it your mood? Is it your ability to eat? Is it your walking? And then we can actually take it from there. So yeah, I don't know if I answered your question, but I really think it's really a lot of conversations and trying to understand our patients in front of us.
Yeah, I mean, I totally agree with you, Kejal. I think the questions that you can ask about frailty are questions that you can work into a conversation with any patient, regardless of age. So I think that's always something to bear in mind when we're having our consultations or conversations with our patients. Thank you. Because we're running short of time, can I get you, Kejal, to look in the chat box to just answer
I'll answer.
questions? And, for other participants who have questions, feel free to put it in the chat box as well. And if we have time at the end, we might come back. If not, then at least Kejal can answer these questions there. Okay. Thank you so much, Kejal. Thank you for that talk. And so now moving on, we're going into our case presentation. So today's case presentation will be done by one of our hub members, Sister Ching Hong from Singapore. Sister Ching Hong is a highly experienced nurse clinician with a robust background in critical care and infectious diseases. Her dedication to advancing her knowledge and expertise led her to complete a Master of Nursing at the National University of Singapore in 2019. And shortly thereafter, she actually joined the National Centre for Infectious Diseases and Tan Tock Seng Hospital as an advanced practice nurse, specializing in infectious diseases, and is also a collaborative prescriber. Ms. Cheng's practice actually focuses on providing comprehensive care for people living with HIV and individuals with infectious diseases, with a particular interest in addressing metabolic syndromes and geriatric conditions in people living with HIV. So I'll hand the session over to you, Sister Ching Hong.
Thank you so much, Frailty. Thanks for the kind introduction. I hope you could see my slides well.
Yeah, they look good.
Okay, thank you. So this case I'm going to share is Mr. T. He's an 81-year-old Chinese male. So he's heterosexual, and the purpose of me seeing him in my clinic is for frailty screening. So mobility-wise, he's wheelchair-bound, both indoors and outdoors. For nutrition screening, dysphagia screening turns out to be negative. He's on soft and a bite-sized texture food, mostly takes porridge on tin fluids with no issues. There's no loss of appetite, loss of weight, and reduced oral intake. Sensory screening, he had left eye cataracts, status post-cataract surgery. He also had right-sided hearing impairment on the whisper voice test. So after I identified this hearing impairment, I also did otoscope to look into his ears. There's no abnormality. There's not even like excessive earwax that I can do something about it. So sleep issue, not really. Although I feel that he does have significant nocturia. Average, he has to wake up 2 to 3 times at night. But he said he did not bother by other symptoms because he wears a diaper. Yeah. So cognitive history-wise, he reported no subjective cognitive issue, but corroborative history from his son demonstrated short memory loss. So, for example, he misplaced his keys and his shavers and couldn't retrieve it by himself. Otherwise, there's no long-term memory loss, no amnesia, agnosia, or apraxia, aphasia, or executive dysfunction. So his operated mental test scored 8 over 10. He lost two points on count backwards and to recall address. For Chinese mini mental state examination, he scored 22 upon 28. So he scored 1 upon 5 for attention, which is very significant. Recall 2 upon 3, and orientation, he only lost 1 mark. So he completed primary school of equivalent to 6 years for education, and so the cutoff for his age and the year of education, he does not really fulfill the criteria for cognitive impairment. But we do see there's a subjective. We do see there's a short-term memory loss issue here. Mood-wise, he has no low mood. He generally very happy and contented with his life. Patient health questionnaire 2 score is 0. So with regard to his activity of daily living, his basic ADLs only independent in feeding, needs assistance in the rest of the domain. For his instrumental ADLs, he's dependent on food preparation, taking medication, and then need some assistance in shopping, housekeeping, and accounting. So physical activity-wise, he still goes to a senior activity center for exercise. So the main exercise he does is seated strolling and stretching exercise. So looking back, his progressive ADL decline all started in 2020 when he had a stroke. So after the stroke, he had 2 to 3 falls. So family decided to employ a helper to help him with his daily livings. So he started to be dependent on the helpers ever since then. Some social history, he's married with 1 son. His risk factor is actually sexual worker contact. He has 5 lifetime sexual partners. There's no substance use history noted. He stays with a wife and helper in a 3-bedroom flat, which is lift-landed. He used to own a traditional cultural medicine shop, but now he's retired. Otherwise, his social support, I would say, is quite good. Helper is the main caregiver, and son brings him for all his medical follow-up. So he has a long list of medical issue. He has a well-controlled HIV, which has been diagnosed in 2004. He presented with pneumocystic pneumonia and oral candidiasis upon diagnosis. He also has type 2 diabetic complicated by diabetic nephropathy with proteinuria. Hyperlipidemia and hypertension are fairly well controlled. Chronic kidney disease with a baseline creatinine of 200. He has not been seen by any nephrologist. Otherwise, he has chronic inflammatory demyelinating polyradicular neuropathy in 2004. He was given AVIG therapy. He also has presumed ischemic heart disease. His echo latest in 2023 shows a left ventricular ejection fraction of 40% with regional wall motion abnormality at septum and apex. Otherwise, he also has vitamin D deficiency, anemia of chronic diseases, UGD and colonoscopy done in 2016. So there's only some gastritis, duodenitis, and diverticulitis. So otherwise, patient has a right cerebellar infarct with foci of hemorrhagic conversion in December 2020. So subsequently, patient was placed on aspirin. And otherwise, patient is type C negative. He is very suppressed with immune reconstituted also. So I will list down some very recent investigation, especially what you can see for the renal panel is done on the day of clinic visit. So he has hyperkalemia with worsening of renal function with a backup of 14.82 ml. So as we can see, the lipid is quite well controlled, but his A1C is like 9.8%. I will show you the medication list later on to see what medication he's on. Otherwise, his ECG was done because of the hyperkalemia, which shows a new T-wave inversion. So I'll pause here for a while for us to look through his chronic medications. Okay, so I did a medication reconciliation on the day. So his main source of medication is from our hospital and also another restructured hospital. And other than that, there's no over-the-counter medicine, there's no medication from general practitioners, or there's no supplement use or traditional cultural medicine use. So his current ART regime is dolutegravir lamivudine, with lamivudine renally adjusted. Previous regime was abacavir, lamivudine, and riprevirin. And before that, lamivudine, zidovudine, and efavirenz was his first regimen. So other common geriatric syndrome screening, I also did a frailty screening. His clinical frailty score was 7, and his sarcopenia screening, the Hungary strength was 19.6, which is low. So he meets the criteria for possible sarcopenia based on Asia work group for sarcopenia. And this SARCF, I think for our first echo session, we have talked about this scoring. So as you can see, he scored 8, which is also suggestive of possible sarcopenia. Otherwise, he has no fall in the past 1 year. There's no change in bowel habits. So for continence issue, he does have nocturia, but using a diaper at night. Patient also have recurrent hospitalization within the past 4 months. So there are 2 bacteremia likely from urinary tract source, and also recurrent fluid overload from worsening kidney function. I think there's some element of medication non-adherence at times because of the Lasix. If you remember, he's on BD dosing of Lasix. So that could be causing some nocturia, causing some, because I think the Lasix was taken at 2 p.m. So which is a little bit interrupted with his other activities. Maybe that's why he didn't take his Lasix for that period of time. So otherwise, for the point of discussion, I would like to know when should we start frailty screening? I think this is the question that actually has been asked because there's really no gold standard as in when, because each cutoff is just one thing. But should we screen patient based on the years of HIV diagnosis or based on the years of ART exposure? So, but I guess Dr. Kejal sort of answered this question. The second one will be, what will be the optimal timing to initiate advanced care planning discussion for this patient, given that the severe frailty state and also multiple medical issue? Yeah, so I'll hand over the time to Dr. Green.
Thanks, Ching Hong. I mean, I think your patient demonstrates that complicated image that Kejal had shared in her slide. But I would like to open the floor maybe to Dr. Weera Sak. I'm not sure if Harzana is on. Weera Sak, Harzana, Jenny, and Grace, maybe to kind of give your opinion on this case and your thoughts about when frailty screening really should have started for this patient, and probably what can we really do for him at this point.
Thank you. I think this patient is he has very obvious physical frailty because as Kejal just mentioned, there are several aspects of frailty. Physical, the patient has a lot of comorbidity and physical mobility problem, functional decline in their function, in his function, everyday function, and also about the poor muscles, hand grip strength, muscle strength. So he has a very obvious physical frailty, though we don't have to use any criteria to demonstrate which tools that we should use for this patient. In terms of social frailty, I think as in the history, there is no obvious social problem in terms of social support and social isolation. In terms of psychological frailty, it seems that he doesn't have any problems about loneliness or depressed or something. And in terms of oral frailty, seems he still be quite okay. In terms of cognitive frailty, cognitive function seems to be no problem or just borderline impairment. So he has a physical frailty. So the domain, if we use the tool, probably in the clinical practice, because we have limited time to do the clinical frailty assessment. So I would think that frail scale is quite okay because it takes very short time or clinical frailty scale as in this patient just to do the frailty screening. But the frailty index and the frailty phenotypes probably we have to have a lot of time, and usually it's used in the clinical research if we have to do a cohort data or something. And so in this patient, he has a frailty. So regarding what time that we should do the screening, I think the first one that we just mentioned earlier is about maybe age. Routine screening may be 50 or 55. Or the second is if he has a lot of if the patient has a lot of multiple comorbidities. But I would like to add some more. For example, if he have cognitive impairment, usually we should assess for frailty as well. And also if there is a care transition, for example, from hospital, if he is hospitalized patient and then he has to go back home, if there is a care transition or just from home to hospitals, we have to assess for the frailty status. And also if he's going to receive any major foreseeing for example, major operation or chemotherapy that we know that he is going to receive in the near future, we should assess for the frailty in that patient. So there are maybe just 4 or 5. Or if he has already the symptoms of frailty, walking problems or weight loss or something like that, in that case, we should assess for his frailty.
Thank you. And did you want to comment on the advanced care planning? Or maybe Kejal, did you want to comment on the advanced care planning?
So essentially, I don't think there's a right time. Any clinical contact with the patient, it's always a good time to start just talking about what they want in their future. But because in our region, it's not something that we are open to talk about, like, oh, what do you feel about if you're unwell or something? So the best time would actually be at any point when he was recovering from an acute stresses. So when he had an infection, he would have seen that he has become weaker, for example. So during that time, you can already plan that, if you become unwell again, have you ever thought, how would you prefer it to be? What are your, So any acute stresses would be a good time, because otherwise, to talk about it, it's not something where culturally is quite acceptable. But actually, the best time is when they are still fit and healthy. Ideally, any advanced care planning discussion should be done in a clinical setting when they're still well, they still have the abilities to make decisions. Sometimes even if they just mention that, I'm a bit concerned, I've slowed down, I have a bit of troubles, I'm not so sure what's going to happen if this happens, use that opportunity to then talk that, okay, have you ever thought if something were to happen, what do you want? Have you ever thought about, then take it from there. So really, any clinical setting when you see the patient, but you must have built a good rapport with the patient. There's no way you can talk ACP when you're meeting the patient for the first time, because you really need a good rapport where they have full trust in you and they know that whatever discussion is done, it's to their best interest as well.
Thanks, Kejal. And Cheng Hong, there's a question in the chat box asking whether we think his frailty is due more to the stroke back in 2020 rather than the HIV. So I'm just wondering what your thoughts are.
I think his HIV has been always well controlled. So I'm not too convinced that the frailty status is due to the HIV infection. I would say it is because of the multimorbidity and also his stroke, yes, in 2020.
Okay. Jenny, you wanted to say something?
I agreed with Louise, who happens to be a geriatrician from my hospital. I wondered actually whether the sarcopenia assessment can be used in the setting of a stroke, given that all of the scores of 2 were actually due to the stroke rather than to muscle weakness. And the stroke and the cardiovascular disease may be related to HIV, actually, and may be related to his antiretrovirals, because he was on abacavir, and I'm not sure when he was switched from abacavir to no abacavir with dolutegravir 3TC. So abacavir is associated with current use with acute myocardial infarction and stroke. So there may be an association with HIV, but it may not be due to poor control of the HIV. It may be due to the chronic immune activation and inflammation that then sets up more atherosclerosis, but also because of the antiretrovirals that he was on previously. But I would be interested in Kejal's opinion about the use of the sarcopenia screening in the setting of a stroke.
Question, Jenny. I would like to think that essentially you should not be using some sub-F for someone who is, say, bedridden or not mobile because of the stroke. But on someone who is already mobile, using the sub-F will only give you an idea that the person has got muscle wasting. Now, whether the muscle wasting is predominantly driven because of the immobility, because of the recent stroke, or because of his accelerated aging, because of his multimorbidity, is for us to determine when we are assessing them. But just knowing that, okay, look, the person in front of me is already wasted, will give you a lot of ideas on how you can intervene. No doubt, the stroked side would definitely have got some muscle atrophy and some muscle wastage. But the idea is the fact that you're just trying to screen the patient. If they're totally bedridden, they're not mobile, then definitely out of picture. But if they're still mobile, even doing that fingering test on the non-stroke limb would probably give you an idea. So I don't think it's completely wrong to use the sub-F in someone who is mobile. But once you've figured out like this person is possibly sarcopenic, for you to figure why is he sarcopenic? Yes, the recent stroke would be one of the reasons, but there's a lot of other things. He also has got heart failure. And I think because of his heart failure, poor effort tolerance, he could also be malnourished in terms of nutrition, in terms of protein intake, and all these can also be driving his muscle wasting.
I do have a question for Cheng Hong. I'm just wondering, for this patient, was he under the care of just the ID physicians, or was he also under the care of, like other teams, like neurologists from the stroke, geriatricians, etc., etc.?
So for his stroke, he was not under any neurology at the time I'm seeing him, because he was followed up by polyclinics. For his diabetic, he's under the follow-up of endocrinologist, and he also has a cardiologist. So not just ID physician alone. Yeah.
Okay. I guess I have two questions following that, actually. The first would be to Pretty, just to ask about, the medications and the polypharmacy. And the second one would be to Harzana, to see, how you would manage someone like this in the community.
Hello, good evening, everyone. Thank you, Dr. Guili, for your question. So if you see here, this patient currently is taking 15 medications, I counted, and some are dosed twice daily and some are dosed thrice daily. So definitely there are polypharmacy issues, and also presence of potentially inappropriate medication, fall risk, increasing drugs, and also this polypharmacy can also result in a decline in functional abilities. So the first thing I would like to highlight in the medication here is the presence of the potentially inappropriate medication, which is omeprazole, which is classified in Beer's criteria. It has been associated with high risk of Clostridium difficile infection and also bone loss and fractures. the quality of evidence is high. So I've noted here that the patient is on a low dose of omeprazole, which I think is more for gastroprotective effect since the patient is on aspirin. So there is no, trials have shown that there's no clear benefit of PPI use beyond 8 weeks. So here I think we may need to review for the ongoing need of omeprazole. And if aspirin is continued for this patient, which is another drug which I was in a dilemma whether it should be continued or not, H2 receptor antagonist can probably serve as a gastroprotective agent. Now, aspirin here, I think, is given for secondary prevention of stroke and cardiovascular event. So I'm on the fence on aspirin. There are pooled trials that have demonstrated long-term benefits of aspirin use that exceeds bleeding risk. And many of the studies have not included age and frailty status. However, I found some data that in age groups of 70 and above, the data on benefit and harm are mixed, and the bleeding risk is increased with age. So the patient here is also noted to have anemia from chronic disease. So I would like Dr. Kejal's opinion on whether or not should we continue aspirin for this patient. And I'll go ahead first. Also, the patient was noted to have nocturia, significant nocturia 3 to 4 times, and I guess that is probably due to furosemide. And I would like to suggest here that probably change the frequency to furosemide 40 milligrams once daily, and monitor clinical symptoms, and also probably to counsel the patient for fluid restriction, because I've noted that he had recurrent admission of fluid overload. And also on the hypertension management, the patient is currently on 3 antihypertensive, bisoprolol, enalapril, which is BD dosing, and amlodipine. And the patient's potassium level is 5.6. So I would like to suggest for this patient, also I would like to know Dr. Kejal's opinion on this, to switch enalapril to once daily dosing of valsartan, because both has data for heart failure. As we have noted, Dr. Sister Chang has noted the ejection fraction is 40%. Or would the patient benefit better from combination pills like Encresto, although I know the cost may be an issue, because this would help to reduce the pill burden and reduce the frequency of administration for the patient as well. I think it's also important to monitor this patient after switching to ARBs to monitor the potassium levels and creatinine. Advise the patient to be on a low potassium diet. And the next would be the diabetes management. The patient is currently on insulatard 10 units BD, actrapid 6 units BD, and glipizide 5 milligram TDS, and HbA1c is noted to be 9.8%. So the recent guidelines have focused more on functional status. So benefits of lower glycemic targets are diminished, and the risk of hypoglycemia is more important. So I've noted that the HbA1c targets should be less than 8.5%. So the issue that I see with this patient is there are multiple daily injections, which I think can be quite challenging for an older adult and who is severely frail as well. And also combining sulfonylureas, although it's short-acting, with insulin also increases the risk of hypoglycemia. And there is also probably compliance issues, and probably we need to recheck on the insulin injection administration methods. So the American Diabetes Association, they have actually suggested simplification of the complex treatment, insulin treatment, to give basal insulin. So here I would off the glipizide and start the patient on basal insulin like glargine, and probably add on analog insulin such as Novorapid after meal if required. And because it has been demonstrated in studies that simplification of insulin regimen in people with type 2 diabetes by switching them to once daily glargine with or without an anti-hyperglycemic agent has resulted in equivalent glycemic control and reduced risk of hypoglycemia. So
Thanks.
I think, oh yeah, and my final one would be the drug interaction between dolutegravir and polyvalent cations. So we can see that the patient here is on calcium carbonate, and co-administration of calcium supplements decreases DTG levels quite significantly. So this patient should be advised to take the calcium supplements in separate timing, that is minimum 2 hours or 6 hours after DTG. So if we do actually implement all these prescribing, I calculated we could reduce the number of tablets from 15 tablets a day to 8 tablets and all once daily dosing for this patient. And I think also ultimately the American Geriatric Society has also recommended to emphasize patient's preference and also be part of shared decision making in their treatment plan. Yeah, that's all from me.
That's really great, Priti. It's so good to know that we can actually do something about this long list.
Yes.
I think you directed some questions either to Kejal or Weerasak about the aspirin as well as the enalapril. But can I just suggest that we keep the responses short so that we have time for our other hub members to weigh in as well?
I think because this patient, he already has ischemic stroke and ischemic heart disease, so the role of aspirin is not the primary prevention, it's the secondary prevention of recurrent ischemic event. So the age limit might be higher than the primary prevention, and he is rarely need the aspirin. But because he is his age is older than 80, usually we are going to we combine with the PPI to prevent the gastric complication in this patient.
So would you maintain it then?
Yes, I think, I'm not sure, Kejal, that you agree with this. And also because this patient, he has the rising of the creatinine and the high potassium at the moment. So the role of ACI and ARB, we have to reconsider about the risk and the benefit. In terms of nocturia in this patient, because he, one thing is about if we can add more, apart from changing the dose of furosemide, maybe a tighter control of glycemia might reduce the nocturia event, because his hemoglobin A1C is 9.8. So probably we have to make a tighter control, and also ask about his prostatic or lower urinary tract symptom from BPH in this patient.
Thank you. Can I just maybe get some comments, some quick comments from Hazana and Kenneth about, how you would manage someone like this in the community?
Hello. Thank you, Cheng Hong, for your presentations. So I'm more curious in the physical status. So I know that this guy goes to senior activity center for some exercise. So I believe this is just a general exercise, right? Not the individualized exercise.
No, it's more like a group exercise.
Okay. And is this guy having any rehabilitations training or therapy?
Right after the stroke, he was in the community hospital for rehabilitation for about 1.5 months.
So looking at the current status, this patient is still wheelchair bound, both indoor and outdoor, right? So physically, this is not very good. I wonder, is it worthy to arrange some community outreach service to these guys? Because some old patients in the past, in my past career, I had some patients who suffer from, for example, pneumonia after HIV, and then wheelchair bound for half year or to 1 year. So after some rehabilitation training, for example, I went their home to do some training for a few months. It can reverse. Actually, it can become a indoor walker or even for outdoor walker for short distance. So I wonder, is it possible to have a try for a short course of therapy so that to see whether we can improve the mobility or the muscle strength, and also because we do not have much detail about the muscle strength and the range of motion here, perhaps we can do some kind of physical therapy to try to improve the physical status.
Thank you for the comments. I think I echo what you say because, and also I have the sensing that for this patient to be so dependent on wheelchair, both indoor and outdoor, there's a heavy component of both patient and the family members' fear of falling. And the patient could be over-relying on the helpers to do everything for him. So I did thinking of to recommend physiotherapy. We do have community outreach program, but the patient did not accept that because, as you could see, that it is quite overwhelming for this single clinic session to cover everything, and also on the day itself, patient also have like a more burning issues to solve, like the hyperkalemia and also a new ECG changes. So actually, it was a very, very long and exhausting session. So I think it is not a right time to propose, like subsequent rehabilitation. But I definitely agree that it is it is feasible and the patient should consider.
Okay, now I understand more because when we want to prescribe some exercise to elderly, sometimes it is hard to do that because sometimes the elderly may not want to be trained sometimes because it's stressful and sometimes it's hard to do that. So thank you for the comment.
Right. Thank you, everyone. I'm really sorry, but we have run out of time for this Q&A. I think it has been a very, very fruitful and useful discussion. And Cheng Hong, I hope this discussion has helped to, give you some idea of how to further manage this case. But yes, we do have a discussion in the iEcho platform. So if there are any kind of further comments or things you want to discuss, you can always put it there. And we can always direct questions to our other hub members as well if you have any questions for them. I do apologize that I can't get everyone to give their input in time, but thank you so much for sharing this case. All right. So with that, I'll just hand over to Norman for any kind of last minute announcements before we wrap up the session.
Sure, thank you so much. Just a teaser for the next session. Our next session is going to be on addressing mental health and substance use. And the didactic lead is going to be Dr. Carl Goodkin, who is based in the US. We've been used to sessions starting at 6 p.m., but because of daylight saving currently, we unfortunately have to push the time a little bit to accommodate for his time that is in the US. So next session will start at 7 p.m. and not 6. And the following session is going to be on healthy longevity. It's going to be led, the didactic is going to be led by Professor Andrea Meyer. And that is going to revert back to the 6 p.m. Time that we are used to. Next up is feedback. We really appreciate you letting us know how we can do better. And also this is required for you to get your certificate of attendance. So feel free to scan the QR code. Joseph, can you send a QR code? Yep, the QR code or the link that has already been sent in the chat box. Otherwise, we can also send this over email. Malaysian clinicians, again, the Google form is in the chat box. And last but not least, case presentation. As you know, the case presentation is a crucial part of our session. And we are still looking for cases for our upcoming session, particularly the one that's upcoming next. And it's also an opportunity for you to learn together with all of us. Don't be concerned around making mistakes. We really see this as an opportunity to learn. Feel free to text us, to drop us an email. You can also drop in a chat box saying me. You don't have to provide us a summary yet. We can send you more information on how you can better prepare for the session, and we can chat more. But we really would like to get more cases from different parts of the world. With that, I think I don't have other announcements. I think we can call this meeting to a close.
Yep. Oh, we'll also be saving the messages in the chat box, and then we can probably upload it to the iEcho platform as well, for people to have a read of the responses if they're interested. So I just want to say thank you to everyone for coming for this session, and hope to see you next month. Thank
December.
you.
Thank you.
Bye.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.